This meeting is now being recorded.
Well, good evening. Welcome to our EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker this evening, I'd like to give an overview of our free program to those attending for the first time. So we'll go over who we are, what is our program, some upcoming events, and introduce our speaker this evening, Dr. Pradeep Chopra. So again, my name is John Furman. I manage National EDS Awareness and Chronic Pain Partners nonprofit organization based in Cincinnati, Ohio. My daughter Deanna, who is also on the call, leads the Cleveland, Ohio EDS support group. She was diagnosed with hypermobile EDS in 2008. The same year, my wife Carol passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. So we introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've been a sponsor for these conferences for the last 5 years. We started over 100 groups to date. Each group is given their own free website with a link from the directory and map. We receive feedback that conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We typically meet each month, 7:30 Eastern Daylight Time. All the recordings and programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers, proceeds from the store, and donations to a nonprofit organization help fund these programs. Please visit our store and check out the helpful products that we offer. Just a general disclaimer, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in these programs. The information is not advice. If you're having medical problems now, please call 911 or the emergency services in your location. Always consult your doctor before making any changes to your treatment.
We want to invite you to join us for our next webinar, June 6th. Dr. Chilimsky is going to address gastrointestinal issues related to EDS. And as we mentioned, we won't have Q&A for this session, so I'll go ahead and introduce Dr. Chopra. He has a lot of information to cover in this part 2 of our 2017 series with him. And he's talking about management of complex pain. Dr. Chopra completed his anesthesia residency and fellowship in pain management from Harvard. He is a professor of the Department of Medicine at Brown Medical School and is double board certified in pain management and anesthesiology by the American Board of Anesthesiology. He is board certified by the American Board of Independent Medical Examiners. He's the author of several publications in chronic pain, including several book chapters. He has a keen interest in both acute and chronic pain management. And among his areas of interest include back, neck, joint pain, arthritis, muscle pain, and, of course, Ehlers-Danlos syndrome, headaches, neuropathic pain, and a wide range of chronic pain conditions. And his approach to treat chronic pain and complex pain is multidisciplinary and multimodality, and includes interventional pain management, physical therapy, relaxation techniques, biofeedback, and the psychological approach. And his goal is to get patients to a point to allow them to do the things they want to do and not let pain take over their lives. And Dr. Chopra has been very, very involved in the Ehlers-Danlos syndrome community, and it's our pleasure to welcome him back to speak to us tonight. Dr. Chopra, your slides are loading right now. I'm going to go ahead and turn over the microphone to you. Thank you so much for being with us tonight.
Thank you, Deanna. Thank you, John. Once again, really appreciate your help. I refer a lot of my patients to your website for, especially the newly diagnosed ones, to your website for more information. We've had some really great speakers. Okay, so this is the second part of a recent series, and I had talked about Ehlers-Danlos syndrome a few weeks ago. I'm just going to sort of skim through the first 192 slides, which we had talked about in great detail the last time, but this is more for refreshing your memory and also for those who weren't able to attend the last one. So we talked about this. I don't have any potential or actual conflict of interest. I will talk about off-label use of medications. Please discuss with your physician your own particular treatment. This is the new terminology that's come out on EDS starting March 15th of 2017. I know there's been some anxiety among the community about the diagnosis, but it really doesn't change in how we diagnose or manage. It just makes it much more definitive. It gives it a much more solid scientific standing within the medical community. So I think in the long run, this is going to be great. The only difference I wanted to point out here was it's now called Ehlers-Danlos syndromes, and hypermobility EDS is now hypermobile EDS, and we use the acronyms small letter H followed by EDS, or vascular will be VEDS, and CEDS for classical. EDS is not a disease. It is a form of the human body. It's just like anything else. There are tall people, short people, black people, white people. They all have their own medical conditions. Hypermobile people have their own medical conditions. It's the connective tissue. The connective tissue is very loose and very lax. And that's one of the basic. There are just two things to remember in EDS. One is that the connective tissue is loose and lax. It's not strong enough. And the other thing is that we'll talk about it is joint position sense. But for management, in terms of managing pain, it's really important to understand what's broken and fixing it. We talk about pain management. There's no such thing as pain management. It's more about, okay, let's find out what's broken. It's like a car. If there's a noise coming in the car, you find out what's the noise coming from. Is it a flat tire or is it a loose nut? And you fix it, and that's how it goes away. So the hard part is finding out what's broken, and then the other challenge is in finding the treatments. So like I said, there are two things to remember in EDS. One is weak connective tissue, and then the other one is poor joint position sense. Connective tissue normally is like rope. You can't stretch it. It doesn't break. In EDS, it is much more elastic. It can stretch, and when it's stretched too much, it stays stretched. And of course, when it breaks, it doesn't heal as well, which explains this kind of a scar. As you can see, this is a typical EDS scar where you can see the middle of the scar is really weak and thin. But the reason I put this slide here is not for its cosmetic value, but to show that what is going on inside the body. If you break a ligament, if you overstretch a ligament, this is how it will heal. Similarly, if someone has surgery on a ligament, this is how it's going to heal, which is going to be a really weak scar. There are two kinds of trauma that are in EDS. One is called the macro trauma, where there's a large event like a dislocation or fracture. And then there's the more common one, which we see on a daily basis, is called micro trauma, where you have repetitive traumas happening on a daily basis, like overstretching muscles, ligaments, and this happens on a much more daily basis. And that's the one that we worry the most about. On the left, you can see a macro trauma. You can see broken bones. You can see dislocated fingers. On the right, you see the micro trauma, where there are small minor tears in the ligaments. The other thing that what happens in EDS is the loss of joint position sense. So we have something that's called joint position sense that tells us our exact position of our joints in space, and that helps us to understand, helps the brain understand where our joints are, and so it protects us. So signals will travel, for example, for somebody walking, signals travel up the leg into the spinal cord, up into the brain. The brain then calculates and figures out, and then in turn sends signals back. There are two reasons for this. One is to protect your joints from hyperextending them, and the other reason is to balance us as you walk. Hence, if you lose joint position sense, most EDSs are klutzy, they bump into things. In children, in toddlers, it's not yet developed, and in the elderly, they lose joint position sense because of prolonged arthritis and wear and tear. Athletes lose them also from the trauma of their work. The way to look at this is to trick the brain by using compression clothing. What that does is it sends a signal from the skin to the brain to the exact position of our joints. And that's why you'll see athletes tend to wear tight clothing. Is one of the reasons is it helps them protect their joints. This is an example of this is a compression sleeve on the knee, and then these are the compression pants. And then we'll talk about in POTS. There's a second advantage to having compression pants is for treatment of POTS, and also it helps with joint position sense. So it's a double win over here. Some of the proprioception exercises are actually fun. They're juggling, they're standing on a wobble board, stroke standing, paddle board. You have a wobble board, stand up paddle board. The second set of exercises are for strengthening muscles. And these are, you have to start really slow and start very low, progress very slowly, and avoid stressing the joints. That's the trick here. This is an important picture I wanted to show you. When exercising, maintain the range of motion. Do not go to the extremes of range of motion. So if this person can go up to 90 degrees, you want to stay at 60 degrees or even 75 degrees. So you don't want to overstretch these ligaments over here. So exercising in water is ideally walking in water, running in water. Swimming is not a good idea, especially freestyle swimming, because it can injure the neck, it can injure the shoulders. Breaststroke is okay to do. The other great technique is called the Feldenkrais method. It's a very non-strenuous exercise technique. It's a very old technique. It helps with proprioception. The best thing to do is to go to this website, feldenkrais.com. You can find, if you plug in your zip code, it'll find providers in your area. You can do this exercise sitting. You can do this exercise lying down. So either one of these is going to be helpful. Just a quick note on what is tendonitis and bursitis. This is a normal joint. So there's a bone here, there's another bone here, there's a capsule around the bones, and then there's fluid inside the bone. So it kind of lubricates the joint. This is a muscle that travels over the joint, and then it becomes a tendon, And when this muscle contracts in this direction, it pulls this bone up. In order to avoid the muscle rubbing against the bone and becoming abraded, there's a little pocket of fluid between the bone and the muscle called bursa. Should this bone move slightly even, what happens is that the muscle and the tendon have uneven forces. And these uneven forces cause this bursitis to get inflamed. So the purpose of this slide is to show that the treatment of bursitis is not rubbing lotions and creams on it. The real treatment is to avoid the subluxation of the joints. That's where it helps the tendonitis and bursitis in the long run. So if someone has bursitis of the hip joint, the trick is to look at what could be causing this bursitis. Is it the way the person is walking? Is there something wrong with the knees or something wrong with the feet? So, bracing or correct posture. So this is a question that often people who are new to EDS come up with is, what is subluxation and dislocation? Subluxation is where the capsule is torn. Sorry, dislocation is where the capsule is torn and the bone moves out of place. And literally, you have to kind of push it back into place. In subluxation, the capsule gets overstretched. So the bone does move out of place, but it keeps coming back. So subluxation is much more common than dislocation. The problem in dislocation and subluxation, the pain is from the capsular stretch. It's not from the bones itself. So in dislocation and subluxation, the pain is mostly from the capsule being stretched or being overstretched, or from muscles around the joint that go into spasm. This is a very good technique to help with some of the proprioception issues, with joint pains, muscle pains, swelling. It's called neuromuscular taping or K-taping. This is what K-tape looks like. It's got adhesive on it, but the pattern on the adhesive is like a fingerprint. So it's almost like someone's very gently massaging the skin and then moving the muscle and joints into place. Normally, a K-tape will last for, officially the companies usually say that it lasts for 5 days. In practice, what we've seen is it's about good for 3 days. Easiest thing is to learn the technique from your physical therapist. They can show you how to do it, or they can teach someone at your house, at your family to do it. And then you can even actually go online, and there are lots of videos on kinesiotaping. It's a really good benign technique. It's something that you can do yourself. This was a study that was published in 2015, where they did kinesiotaping for an EDS knees. And this is a great technique. It's really simple to do it, and you can actually do it yourself. Now, so then what I had done the last time, a few weeks ago, was I'd gone through pain and EDS by body regions. Remember, I had said that it's really important to find out what's broken in order to help the pain. So I'm going to go through different areas: head, neck, shoulders, arms, abdomen, spine, legs, head and neck. So there are lots of reasons for headaches in EDS. There's Carey malformation, and then there's muscles around the head and neck. There's temporomandibular joint dysfunction, blurry vision, POTS, tethered cord, spontaneous CSF. So I'm going to touch on all of these. But remember, because this talk is in relation to EDS, and this is a different set of slides. But you can also have headaches for just usual causes, including migraines. Migraines are common in EDS. So I'm not going to touch on these, but briefly explain cause of headaches in EDS. One of the common causes of headache is posture. So there's a chin poking forward position. So a normal head is has a pressure of about 10 to 12 pounds. So when your ears are in line with the shoulder, when our ears are in line with the shoulder, the pressure on the neck and head is about 10 to 12 pounds. If you lean forward by 2 inches, the pressure now almost triples. It's about 32 pounds. And then if you lean forward by 3 inches, it now becomes 42 pounds. So that's a lot of pressure on the spine and the head. These muscles around the head and the neck that tether the head to the spine are overstretched. They're in a spasm, and that's one of the reasons why people with poor posture get headaches. Poor posture can cause neck pain. It can even go down to back pain. So why do people with EDS have poor posture? One is they have blurry vision, which comes and goes. There are lots of reasons for having blurry vision. It's mostly because of the thickness of the eyeball itself that can do it. It's a fluid balance that causes the vision to change. There are lots of vision issues, other vision issues. POTS is something else that can cause headaches, common poor postures. Spinal ligaments are lax, so you depend on your muscles to hold you in place. And then, of course, there's instability or cranial cervical instability that can cause poor posture. Ideally, your posture should be by an imaginary line extending from the ear down to your shoulder. In the beginning, it's kind of tough to do that. It actually hurts a little bit to do it, a little uncomfortable, but given time and practice, it does help a lot. This is another reason, again, leaning forward and looking at your phone. So bring the phone up to your head so your ears are in line with the shoulder. Migraines is very common in EDS. Just to differentiate, this is a slide to differentiate between the different types of headaches. A sinus headache is more around the nose and the front of the head. Cluster headaches are basically someone stabbing your eye. Tension type headaches can be in the front and can be in the back of the head. I don't have that slide, but pain from TM joint, temporomandibular joint, is usually on the sides of the head, and the migraine is usually one-sided. It's classical. It comes with nausea, and it's classically a throbbing headache on one side of the head. The other reason for headaches, intractable headaches in EDS, is idiopathic intracranial hypertension. It's also known as pseudotumor cerebri. There's no tumor, it's just pseudotumor cerebri. Basically what happens is, in this case, is that there's a vein in the brain that's narrowed down, and that causes an increase in pressure inside the head. Patients usually present with visual disturbances, sensitivity to light, ringing in their ears. This is often a very unrecognized cause of headaches. It's called spontaneous CSF leak. So the brain and the spinal cord is bathed in a fluid, which is called CSF. And the CSF circulates around the spine. So this CSF moves around the brain, and then it floats. It moves around the spine, comes back into the head. So everything is floating in it. What happens in spontaneous CSF leak is that these people develop small holes in the bag that holds the fluid, and classically patients present with headaches that almost go away when you lie down and come right back as you sit up. It is impossible, almost impossible, to find where the hole is or how many holes there are. But the classical picture is the headache goes away as soon as you lie down, comes back as soon as you sit up. Upper back pain is usually because of poor posture again, rib subluxation, repetitive use of your arms, and in women it can be the weight of the breast tissue itself. So in women, to get your posture back, the best thing is to use a sports bra with a racer back. And so that's a racer back. It should have a front closure. And what it does is it pulls your back. The important thing here, again, to note is the front closure. It should have a thick strap, and then it should have a racer back on the back. The crossover should be higher up, not that low down. If you can only find something that's as low down, you can get a bra clip that'll hold these two together. Again, compression garments to help with improving proprioception. Neck pain. Neck pain, I've sort of divided it into two parts, but the issues with neck pain is craniocervical instability. Mostly there's an instability of the C1, C2. There are 7 of them, so the C1, C2 are the topmost ones. Chiari malformation can do it, and then cervical disc degeneration can do it. So I divided neck pain into 2 parts, craniocervical instability into 2 parts, CO to C2. Excuse me, O stands for occipital. So oftentimes these patients present with, of course, headaches, neck pain, but they also have dizziness, they have tingling and numbness to their face, ringing in their ears, sense of anxiety, poor balance, lightheadedness. This, if you see this is, for those who know what POTS is, this kind of matches up with symptoms of POTS also. Now, what happens is that there's an artery that travels through the neck, through the spine on each side. It's called the vertebral artery. And in people with craniocervical instability, turning the head to either side can compress the vertebral artery on the other side. And these patients will present with ringing in their ears, fainting, blurred vision, difficulty swallowing. So again, as you can see, these are symptoms that are pretty similar to POTS and dysautonomia and Chiari malformation. Treatment is usually starting with the most basic things, neck brace, strengthening the muscles, and if all else fails, surgical fusion. So for the lower part of the cervical spine, C3 to C7, it's more of muscle spasms in the neck and upper back. There's a cracking sensation in the neck, there's neck pain, and then there's tingling and numbness in the fingers. In the CO to C2 that I talked about was tingling in the face. This is called the Barry-Lou syndrome. Barry-Lou syndrome is an interesting phenomenon. It is this is the cervical spine, so there's the neck. Plastered to it, right in front, is a sympathetic chain ganglion, cervical sympathetic ganglion. These are nerves belong to the system that controls flight and fight in our body. So it's responsible for the increase in heart rate. It's responsible for blood pressure, things like that. Oftentimes, patients do present with the syndrome if they have cervical instability, difficulty swallowing, numbness of the tongue, blurred vision, tinnitus, dizziness. Again, there's an overlap in symptoms with cervical instability, with POTS, and Chiari malformation. Basilar invagination, again, this is an MRI diagnosis where the C2 starts to press against the brainstem. We talked about this the last time. The important thing I wanted to talk about here was that the pictures, the imaging for this is you need functional imaging technology, which means it shouldn't be a static picture. It should be, if it's a CT scan or an MRI, it should be in flexion. Another one in rotation. Rotate the neck left 90 degrees. Rotate the neck right 90 degrees to see how much of the vertebra are moving. So you want to see the translation of the vertebra as they move. This is really important for diagnosis of craniocervical instability. Now, this slide, I put it in there is because neurosurgeons who work on craniocervical instability like to see these measurements. These measurements are not done routinely. They're only done on special request. But if you already had an MRI with the rotational films, it's okay. The radiologist can go back and measure these angles even on MRIs that have already been done. There's a clivo-axial angle, there's the Harris move measurement, and then there's the Grab-Oaks measurement that they like to see. Again, strengthening the neck muscles, hard cervical collar. Symptoms of temporomandibular joint pain. So these are our joints. These are the muscles that we use. These are just two of the muscles. There are a bunch of muscles inside that are responsible for the lateral movement, the side-to-side movement as we chew. So there are a ton of muscles that are involved in chewing and grinding. Pain from temporomandibular joint is usually, as you can see over here, it's more on the side of the head, goes into the jaw. It even goes down the neck and into the upper back. Again, the overlap, you can see the overlap again with neck pain, headaches. So look for the simpler things first. If you have headaches, look for temporomandibular joint pain, look for postural changes first before moving on to the more exotic ones. Oftentimes patients will have clicking noises, they will be clenching, grinding, they have pain on opening their mouth wide, jaws lock up. This is very common. I mean, this is a figure, I have it at 70%, but literally I think almost every EDS patient that I have seen has had TM joint dysfunction. I would avoid over-the-counter mouth guards. They actually, if they don't fit well, they make you grind more and clench more. Also, they don't really prevent you from clenching and grinding. All they do is they protect your teeth. Dental issues in EDS is huge. There are tons of them, and it's a very neglected area in treatment of EDS. We talk about it more as we go into mast cell activation syndrome. Remember, everything that you eat, as we eat, goes through our mouth. And if our mouth is not clean, if there's inflammation going on, if there's infection going on, we're not really getting healthy stuff into our bodies. Some of the dental issues in EDS are teeth. They are weak. They have a thin enamel. They crack easily. They are prone to cavities. Big major issues with gums is connective tissue. So they have gingivitis is very common. Again, if you have gum surgery, healing is delayed. Tissue breaks down easily. They have lots of pocketing, gum recession. To cap it all, numbing medicine may or may not even work in these cases. But again, what I wanted to show you was the very high incidence of gingivitis and it's just not in the non-EDS population as well as the EDS population. Inflammation of the gum is called gingivitis, and this increases the inflammatory reaction of the body, and it's been shown again and again that gingivitis can cause, people with diabetes and arthritis have a higher incidence of gingivitis, and it's known to cause these conditions. This I came across, I've been looking at it for a couple of years. It's a dental gel called Levonex. It's manufactured in the United States. It has a very unique method of action. It doesn't have any salicylates, which is known to trigger mast cell. It doesn't have any of the gluten, sugar, chemicals, color dyes, no harsh abrasives. We already have thin enamel over there. It helps rebuild enamel and disrupts plaque formation. So if there's a plaque formation, it disrupts that. It helps repair connective tissue to close those pockets. It's a really, I've been looking at this for about a year or two now, and I've been looking at the research that's come out of this. It's worth looking at. I don't think you'll get it at the local stores. Amazon has it, and I think you can go to their website and they'll have it for you also. Carry malformation is another common condition in EDS. There's neck pain, balance issues, dizziness, difficulty swallowing. Uh, Complex Chiari, there's something called complex Chiari, which is a combination of having Chiari malformation, sleep apnea, POTS, and cervical instability, craniocervical instability. What is Chiari malformation? So this is the brain, and this is the hole through which the brain comes out. Or, I'm sorry, not the brain, but this is the hole through on the skull from where the brain becomes a spinal cord. And this is the normal. In Chiari, what happens is this starts to poke down in through the hole, and there's a compression of the brainstem as well as compression of this flower-like thing. It's called the cerebellum, which is responsible for balance. And so that's why you see a lot of balance issues with patients with Chiari malformation. There's a higher incidence of Chiari and EDS. This is an MRI that I had shown the last time, was to show that the importance of getting a sitting MRI. This was the same patient in a supine position. They measured the clivo-axial angle, and it was 141 degrees, which is about normal. When you did the same patient in a sitting position, it was 133 degrees. And you can see, this is the cerebellum that I talked about. You can see how it's poking through. And it's poking right through this hole here. So it's really important to have an MRI in an upright position, especially in patients with EDS. And these angles, I put this slide again to stress how important it is to have those angles. Pain in the back. So spinal pain, there's lots of reasons for having spinal pain. It can be from joints. There's spinal instability from muscle spasms. SI joint pain, it is a part of your pelvis. This is a really good brace that is actually designed for women by this company, and it's a great brace. I like it. It works for patients with SI joints and lower back instability. Tethered cord syndrome. So this is where patients come up, have lower back pain, unexplained lower back pain. They have what is called neurogenic bladder, leg weakness, muscle abnormalities. This is what it looks like. So in the normal, the spinal cord ends at L1. And then after that, it's a phylum. It's a thin thread that hangs loose in the spine. In tethered cord, this phylum is connected. It's attached to the bottom. It's tethered there. And it pulls the spinal cord down from its L1 position. And oftentimes there's fat infiltration on it, which shows up in an MRI as fatty infiltration. But in general, an MRI is not helpful for diagnosis of tethered cord. It is mostly on physical examination, history, and bladder testing. This is what I want to say. MRI is not a useful diagnostic tool. A urodynamic study may help connect the pieces, jigsaw pieces, to get a full picture. This is what it looks like. I got this slide from Dr. Klinga, and you can see over here the cord is so tight over here, and you can see blood vessels in it, and you can see fat infiltration in there. What they do is they snip it, and then they snip it here, and there it is. Neurogenic bladder is where patients have increased frequency, urgency. They have a sense of incomplete evacuation of bladder. So it's like they finished peeing, but it still looks like they haven't finished peeing. They may have incontinence or urine, usually more than 3 urinary tract infections in a year. Breathing. This is again, oftentimes patients with patients with EDS will have issues on breathing where they feel like they're not able to take a breath in, and they have to actually voluntarily take a breath in. And what happens is that the ribs move up and down the diaphragm moves down, the ribs move up when you inhale, the ribs move down when we exhale, the diaphragm moves up. So there's a lot of movement of ribs, bones, joints, muscles, and like everything else, there's the loss of proprioception. The brain doesn't quite know where the chest wall cavity is, so the muscles go into a spasm, and that causes chest wall pain. They have these breathing issues. Fortunately, the treatment for this is pretty simple. You can lie on your back and place a book on your belly button and breathe in and breathe out for 20 minutes a day. The other one is to lie on your stomach, put a 1.5-inch rubber ball under your belly button, and breathe in, breathe out for 20 minutes. And the third one is sing, high notes, low notes. This will help with rib subluxation, playing a recorder, which also helps with not only just the breathing part of it, helps with costochondritis, and also helps with proprioception of the fingers. Pelvic pain, these are the three common ones: dysmenorrhea, painful menstrual period; dyspareunia, painful intercourse; and sacroiliac joint dysfunction. Dysmenorrhea is brutal. The best treatment for this is to stop menstrual periods. Birth control pills are the best way to do it. It also helps with joint laxity. There's one more, interstitial cystitis, which I forgot to mention. It may be part of mast cell activation syndrome. Drugs that are known to help mast cell activation syndrome might help interstitial cystitis: cromolyn, ketotifen, quercetin. There is a medicine called palmitoyl ethanolamide, in short known as PEA. This has also been shown to help with some of these mast cell issues and can help interstitial cystitis. For dyspareunia, it may be part of mast cell activation syndrome or EDS or both. One of the treatments that actually, there was a study that came out where they used hyaluronic acid locally. You can buy it. It's over the counter. Try Amazon. You can find it there. Pain in the arms. This can be from the shoulder joint, where you have laxity of the shoulder joint muscle spasms or rotator cuff, or thoracic outlet syndrome. This is what it looks like. Classically, pain going from the neck going down the arm. Treatment is physical therapy, kinesiotaping, Botox, surgical intervention. Hands and wrists is another major reason. One is that because of poor proprioception, patients with EDS tend to grip things very tightly. So when they're writing, they'll hold the pen really tight. When they're driving, they hold the steering wheel too tight. And what happens is that causes the muscles in the hand to wear out quickly, and then that's how they fatigue. The muscles fatigue and they have pain, and then of course it stresses the joints. They tend to hold the pen very tight. Again, for holding a pen or any instrument is to use this. It's a dense foam tube made by a company called Ableware. You can use it for toothbrush, forks, knives, spoons, anything like that. Or you can use a fingerless compression glove. That will help with proprioception. For steering wheels, it's really easy. You can get a steering wheel cover that has foam on it, and it thickens it up. It really helps. For finger dislocations, these are splints, really nice metallic splints that keep the fingers in position. It prevents excessive movement of the joints, which helps prevent straining the muscles. Splinting and bracing in general, the theory that bracing makes muscles weaker is wrong. That's not true. It's actually the opposite. It helps muscles because it helps maintain the joint in a neutral position, and it starts to aligns the joints, and you tend to use your joints much more. So the braces that we use are not that tight that they prevent the muscles from working. They basically go around the joints, the bones. Oh, that's it. Do braces make your muscles weaker? No, that's a misconception. Pain in the lower half. So pain in the lower half of the body is to first look at the ankles and the feet. If your ankles and feet are unstable, that makes the knees unstable, which makes the hip unstable, which throws the SI joint off, which throws the spine off. So in order to treat all this chain, is to work from the bottom of the chain, is to look at the feet and ankles. Flat feet, if you look at, all you do is look at your feet from the side and you'll see there's no arch there, it's flat. If you look from behind, you'll see the knees are turned in, the ankles are turned in. There's overpronation, and it's usually because of flat feet. And you can see the pressure, the weight on this patient is coming to the side of it's missing the ankle joint, it's going to the side of it. Exercising your feet is to, again, barefoot walking makes the muscles stronger. Really important to wear shoes with laces on them. Cushioned midsole. You can get orthotics. So orthotics to stabilize the feet. Again, introduce them slowly. Start with an hour a day for a week, then 2 hours a day for a week, and so forth. For an unstable ankle, it's best to use an ankle brace. Knees, usually they have hypermobile patella. The kneecap is usually hypermobile. And because of a hypermobile kneecap, they have pain in their thighs. This is a very nice knee brace. I like it. It has two straps, one in the front, one in the back, one in the front, one in the back. So it really keeps the brace in place. There's a little donut that keeps the kneecap in place. And more importantly, there's a metal strut on the side that prevents it from hyperextension. I'm going to skip this just for time. We have discussed all this on my last presentation. Abdominal pain is huge in EDS. It's from gastroparesis. It can be from laxity of the intestines. It can be prolapse of internal organs. Mast cell syndrome, activation syndrome can trigger that, trigger gastroparesis or motility issues. I believe your next speaker will be talking about GI issues. This is a really interesting diet. It's called the low FODMAP diet. If you go to this website, ibsdiets.org, you'll find a complete listing of foods. It's definitely worth trying this diet. It helps with abdominal pain, bloating, diarrhea, alternating diarrhea, constipation. There's a book. I have not read this book, but I looked at it online. It's something to look at, or you can simply go to ibsdiets.org and it'll give you a list. For those, in case you have an infection or something, the antibiotics to avoid are fluoroquinolones, like Cipro, which are known to cause tendon rupture and makes it much more riskier in EDS. Behavioral, this is definitely not the pain and the functional issues in EDS are definitely not from your head. It's real, and it's something to be careful about. If you find your physician tending towards seeing a psychiatrist or behavioral and not talking about actual management of the condition, that's a red flag. And to children get diagnosed with conversion disorder or Munchausen by proxy, which I think is very, very unethical. And unless they have a concrete evidence, they should not be diagnosed. It's not something that you make a diagnosis easily. So just to be on the safe side. POTS, we talked about POTS. POTS is part of a condition, is part of under the umbrella condition of dysautonomia. Patients present with faintness, dizziness, heart racing, but more importantly, they present with fatigue and poor concentration or brain fog, and a sense of constant anxiety. These are the three things that bother them the most. you can figure out your own POTS, measure your blood pressure and heart rate while lying down, and then again for standing for 10 minutes. They often do a tilt table test, which is, if you have POTS, it is not a fun test at all. Usually there's a change in heartbeat, heart rate. The blood pressure remains pretty stable, but the heart rate jumps up. Generally, if it jumps up by 20 beats, is diagnostic of POTS. Treatment is to increase oral salts, oral fluids, compression types. This is a very nice website to look at, dysautonomiainternational.org. They have all sorts of recipes for high-salt diet, all sorts of information. This news. The problem with POTS is that the feeling of dizziness makes patients feel unstable, and then they already have lax joints, ligaments, and that makes them even more unstable. So this is where we come in today. Ehlers-Danlos syndromes. I wanted to go with mast cell activation syndrome. You've had some really amazing speakers. Dr. Maitland has talked about mast cell activation syndrome. Dr. Afrin has talked about it. I'm just going to simply add my 2 bits to it and see how it connects to pain. So mast cells are normal cells found in the blood. They contain histamine and cytokines, and if they are triggered, they release histamine and cytokines. Histamine is what causes the typical rash-like symptoms. Cytokines are what triggers pain. It is not to be confused with mastocytosis. There's a condition called mastocytosis. In mastocytosis, the number of mast cells increase. So you can actually see the number of mast cells that have increased. In mast cell activation syndrome, there is no increase. It's just that they get activated really easily. This is a graphic that I borrowed from Dr. Maitland, and you can see there are lots of mediators released by these mast cells. The 2 important ones that I wanted to show you for pain are cytokines and histamine. They are both known to increase pain and decrease function. The best way to describe mast cell activation syndrome is that it makes you feel like you have a flu. You feel cold, you feel yucky, you feel achy everywhere, and just blah. It's not every day. It's days when your mast cell is it's a bad mast cell day. That's when you feel that, and that's exactly what happens in flu. Is where our mast cells are activated. This was a paper that was published in 2015 where there was a lot of head scratching. They said there's a new disease cluster with mast cell activation syndrome, POTS, and EDS. So people are looking into it and saying, like, what is the connection between these? We can connect the dots between POTS and EDS, but it's really hard for us to connect that mast cell activation syndrome dot to EDS. It's more challenging. We're not quite sure why people with EDS present with more symptoms of mast cell activation syndrome. This is a very nice book written by Dr. Afrin. It's a pleasant read. It's an eye-opening. I found it very useful. It's worth looking at that. Never bet against OCHAM. So, what are the symptoms of mast cell activation? There's unexplained skin flushing, unexplained hives, itching, headaches, sweating. The sweating is usually like you wake up sweating. There's flushing after a hot shower, brain fog. Remember we talked about brain fog in POTS. So there's brain fog in mast cell activation syndrome. There's belly pain. They have alternating diarrhea and constipation, and dermatographism, where you can actually put a scratch in the skin and you can see it. So what are the signs and symptoms of mast cell activation syndrome? The commonest are skin signs, which are hives, itch, and rashes. Then you see brain fog, headaches, dizziness, confusion. See how it matches up with symptoms of POTS also. And again, is the headache from mast cell? Is it from POTS? Or is it from Chiari malformation? And that's where a good history and physical examination by the physician comes into play. They have a fast heart rate, palpitations, dizziness, fainting, GI issues, nausea, there's cramping, there's abdominal pain, vomiting, diarrhea. It's usually because of motility issues. Genitourinary, uterine cramping, frequent urination. This is where I think a lot of the symptoms of interstitial cystitis, including bladder pain and bladder burning, come in. Oftentimes people with mast cell activation syndrome will have burning when they pee, but when you test it, there is no organism, there's no bacteria that they can see there. And then of course there's chest tightness and wheezing, the classical asthma symptoms that come out from mast cell activation syndrome. And then finally there's it's a really deep bone pain, muscle pain, muscle achiness that also comes from this. There is no test that is considered as a gold standard. Testing for mast cell is a nightmare, and I'll show you why. One, because mast cell activation syndrome waxes and wanes, so some days are worse than other days. But preparing for a test, you have to stop all proton pump inhibitors of the family from omeprazole, Tylosin, etc. for 5 days. You stop all NSAIDs like ibuprofen, naproxen for 5 days before the testing. Stop salicylates for 5 days. Salicylates are not just, these are aspirins. Salicylates are found everywhere. There's this website called salicylatesensitivity.com, and you can see which substances, our daily use substances, have salicylate in them. They're found in things like toothpaste, dried fruit, apricot, avocado, black. I just picked a few random ones. Canned foods have them. Seasonings have them. And almost all seasoned meats have them. So you've got to stop all this 5 days before the testing. This is, again, I put this in today. Again, this is Livernex. Eventually, the lab needs to have chilled. They have to do, these are the tests that they need to do. It has to be chilled right away. So chilled serum tryptase, plasma prostaglandin, chilled random and 24 urinary prostaglandin. So 24-hour urine samples have to be collected, which means you pee in a bottle and you store the bottle in a fridge. So these are some of the issues with testing. And labs, there are only 3 labs in the United States that actually test these substances. And so the sample has to be shipped out from wherever you are. And the lab people have to be really educated on how to do this. So talk to the lab before testing. The specimens have to remain chilled all the way from collection to the lab where it's being tested. One of the things is that if you've had a biopsy, a GI gastrointestinal biopsy, you can request the pathologist to recheck the biopsy sample staining CD117, or there are some older stains that they can do for mast cells. They don't stain for mast cells routinely, so you'll have to actually specifically ask for that. And if it does show up on a GI biopsy, if it does show mast cells, then you're good to go. I don't usually have patients do these testing, mostly because it's so difficult. And even if you can manage to do it, it's positive in about 30% of the cases. For me, it's just better to just go ahead with the treatment. But if there are symptoms that make you feel like unusual, odd, and weird or bizarre, and allergies to everything, think of mast cell activation syndrome. Some of the common substances that can trigger mast cell are NSAIDs, which is ibuprofen, alcohol, narcotics can do it, sudden temperature, so that's why coming out from a hot shower into a cold bathroom can do it. The problem is with inactive ingredients. Inactive ingredients like, so drugs contain active and inactive ingredients. Binding agents, preservatives, color dyes can trigger mast cell. Seasonings can do that. Dairy products, eggs can do it. Most grains can do it except quinoa and rice. Beef products do it. It's okay to take lamb, venison, or poultry. But again, even though I say it's okay to take it, but it still might trigger mast cell. It all depends. A lot of it also depends on what the chicken was fed in order for you to develop a reaction to it. What was the lamb fed for us to develop a reaction to mast cell? The chain goes as far as that. So detecting that is really up to the patients to figure out what's triggering it and what's not triggering it. Some of the other methods. So in my theory is that there are only three ways that you can get a trigger. One is you can eat it. The other is you can breathe it. And the third one is you can apply it. Applying it is, the usual cosmetics. A lot of the cosmetics have preservatives, dyes, or whatever, salicylates. So look for those. Eating it is, we talked about the eating it, foods that can trigger mast cell activation syndrome. And then in breathing it is there pollen coming into the house? Is there mold in the house? So use HEPA air filters. Use HEPA filters on the air conditioning. Wear a mask while dusting or vacuuming. While vacuuming, have a HEPA filter in the vacuum. During this season, so this is spring right now over here, when there's a lot of pollen in the air, you can do frequent nasal saline washes. Treatment for mast cell activation syndrome is, of course, the most important treatment is to prevent the triggers. The second thing to do is the drugs. The drugs, we have antihistamines, hydroxyzine, cetirizine, which are basically cold medicines. They work well. Ranitidine, famotidine, which are drugs used for acid reflux. Quercetin is a good compound. It's over the counter. I like to use a Solgar brand because it's made in the US. It comes in a glass bottle. That's the other thing I want to mention. Drugs that come in plastic bottles can trigger it. Solgar makes it in a glass bottle. They don't have soy. They don't have gluten. They don't have a bunch of things. Cromolyn. The problem with cromolyn is that it's not absorbed well. And the liquid cromolyn comes in a plastic vial. It's actually a very cheap plastic vial. And some of the patients have been reporting reactions from cromolyn, which is sort of bizarre, but I think that it might be chemicals leaching out from the plastic into the cromolyn itself. Ketotifen, you can use singular, and of course dietary changes. We talked about that. This is, I just talked about this was the medicines that have the active and the inactive ingredients. Look at the inactive ingredients. So, for example, if you take a tablet of Tylenol and you have itching and rashes, it might be just that the inactive ingredients like the binding agents, the dyes could be doing it, the preservatives in it be doing it. Sometimes when you switch to a different brand, you might see a better result. Oftentimes, if you go to the children's section in the pharmacy, you can get these dye-free, sugar-free medicines that you can use. If all else fails and the medicine is really essential to take, then a compounding pharmacy can make it and leave out the inactive ingredients. So we've talked about EDS, we've talked about POTS, mast cell, and this is where we start to connect the dots. So patients with EDS, POTS, and mast cell present with all of these: headaches, brain fog, dizziness. They have blurry vision. They have a racing heart, belly pain, muscle tremors, dark discoloration of their feet. So who's contributing to what is very difficult to tease out. But the way to treat it is to treat each one of these. If you have all of these three, start with treating each one of these separately and basically that's the only way to do it. There's no one fix for all of them. So if it is mast cell that's acting up, treat the mast cell, treat the POTS, treat the EDS. This is something that we've started looking at. There's more and more literature coming out on nerve pain in EDS. So the nerve pain that I want to talk about was complex regional pain syndrome, which is a form of neuropathic pain. Basically, there are three kinds of pain in our body. So there's structural pain. So if there's if your bone is dislocated, so there's pain from that. Then there is neuropathic pain, where the nerve itself is painful, and then there's the mixed variety, where you have both structural and nerve pain. Most cases of chronic pain have a mix of both. Some of them, in some cases, the structural pain may be more than the nerve pain, and in some cases, the nerve pain may be more than the structural pain, but in most cases, it's both, or a mixed variety. It's a chronic, widespread pain is common in EDS, but part of this pain can be neuropathic. Not all of it may be neuropathic. In CRPS, pain usually starts in one limb. It is a constant pain. It's there even at rest, and it shoots up spontaneously. There's no rhyme or reason. You could be sitting there watching television, and boom, it'll shoot up, and then it'll drop down. It'll shoot up. It's very severe. Oftentimes, there's temperature asymmetry, so one limb might be colder than another. There's color change, so one leg will have a different color from the other leg. There's swelling. Usually, the area of pain is larger than the primary injury, and sometimes there's limited range of motion because of the pain. There's allodynia, which is pain to touch. Then there are parts that will have a creepy, crawly, uncomfortable sensation, which is called dysesthesia. Nails may grow faster. They might be distorted. Hair might grow faster. It might be coarser. It may fall off. There's atrophy of the skin becomes thin, and there may even be blisters on the skin. This is a picture of CRPS. You can see that it's in the right hand. The color, you can see the marked color difference. You can see the swelling around the wrist over here. Over here you can see the bones. Here you can't see them. This is another one where I wanted to show you there was a color difference, there's a temperature difference, and then you can see the swelling. You can see the marks in the socks. The nails, this is the toenails. The nails can be hands or toenails. They get brittle. They look distorted. They break off easily. Fatigue. This is a real challenge in EDS, and especially it's a bigger problem in kids. Surprisingly, I'll have children in my office who will complain of pain, but it's the fatigue that bothers them the most. There's plenty of reasons for having fatigue in EDS. The EDS itself can cause fatigue, and I'll show you why. POTS can cause fatigue. Mast cell activation syndrome can cause fatigue. You're constantly producing histamine and cytokines, and it feels like, remember I told you it feels like flu, and that's what it feels like. Some of the medicines to treat these conditions can cause fatigue. For example, the antihistamines we talked about, they can make you feel drowsy, and pain medicines can make you feel drowsy. The pain gets to you, and that makes you feel fatigued. Poor sleep, which is non-restorative sleep, I'll touch on that later on. And then there's this question mark of secondary mitochondrial dysfunction. So there's a lot of debate on this topic, but specialists who treat mitochondrial dysfunction have told me again and again that there's very likely that patients with EDS can have mitochondrial dysfunction. Briefly, mitochondria are the power cells in our body. They're rechargeable cells in our body, and basically what happens in mitochondrial dysfunction is that these rechargeable cells aren't really charging up well enough. So they discharge very quickly. So here's the comparison between non-EDS and EDS patients in terms of how they get pain. So in the non-EDS patients, you can see the muscles are relaxed at rest and they only contract when there's activity. In EDS, the muscles are tensed even at rest because they're constantly trying to stabilize you. In non-EDS, the ligaments are tensed at rest because they support and stabilize the body. So the ligaments are working, the muscles are relaxing in non-EDS. In EDS, the ligaments don't provide any tension, so they're pretty useless. So it's the muscles that we depend on to hold us constantly, and so it puts a lot of strain on the muscles. One of the issues about EDS, fatigue in EDS is, well, the fatigue is so bad. How about we stimulate the nervous system and see if it'll help with this fatigue? It's not the best choice, but it may be a good temporary measure to use a stimulant to get over that hump so that you get enough energy to, say, exercise and get things under control. But of course, the best thing to do is to treat the underlying cause, take frequent breaks, do not push through fatigue, take adequate hydration. Again, with POTS and Mast, you need to be hydrated well. This is I'm sorry the print is so small. I was just being lazy about pre-typing the whole thing. But you can pretty much take it when John sends in the slide, you can copy it off. But this is a mixture it's more like a mitochondrial mixture that I've been using for some time, and we find it pretty useful. It's not amazing, but it's another tool to help combat fatigue. Ubiquinone is a form of CoQ10. Riboflavin is B2. Acetyl-L-carnitine provides the phosphate bonds, and then the vitamin B complex. I'm sorry, the only thing that's missing on this is folic acid, and they can add the folic acid. And any compounding pharmacy should be able to make this. There are other treatments like oxygen, hormonal modulation, levodopa, Epsom salts, topical analgesics. I'm going to talk to you a little bit about each. This is anecdotal. We don't have a study. There is a study coming out. They've got the data. It's actually coming out of France where they've given oxygen to patients. I think it makes sense, but we'll have to see what the results of the study show. I'm hoping the study will be published this year. So oxygen by a non-rebreather mask. This is what a non-rebreather mask looks like. There's a little bag there which doesn't inflate. You can get one of these on Amazon easily. 3 liters to 5 liters, 20 minutes per day, up to twice a day. It can help with symptoms of fatigue and dizziness. Levodopa carbidopa combination is marketed in the United States as Sinemet. Sinemet is a drug that's approved for rigidity and muscle spasms in Parkinson's. It's very good it's very helpful in patients who have muscle spasms and dystonia. Start with a low dose, and it's also great for restless leg syndrome that I've been seeing for some reason in patients with EDS. So restless leg syndrome, dystonias, muscle spasms. This is a good way to go. One of the reasons is that, like I showed you before, people with EDS depend on their muscles to hold them in place. Relaxing those muscles may not be helpful. So taking muscle relaxants is not the best method to do it. Levodopa carbidopa Sinemet is not a muscle relaxant. It works at the level of the brain. It increases the dopamine level there. And so it may be a better choice as a muscle relaxant for muscle spasms and dystonia. There's no studies to show it. I think they're doing a study right now, so we don't have the results. It's just experience and anecdotal experience. So one of the concepts about pain is oh, you should exercise, you should do physical therapy. That's the only solution. True, physical therapy is helpful, but how much physical therapy? How far should you go? Is it the no pain, no gain philosophy? No, it's not. You have to go really slow, start low, go slow. So if the recommendation is, for example, 5 pounds, 5 pounds of weight, 20 reps, I would say start with 1 pound and do 5 reps. Stay at that level for a week. A week later, go to 7 pounds and 5 reps. So progress very, very slowly, because remember, if you do damage your ligament or your muscle, it takes forever to heal. So one misstep can put you back for a long time. Service dogs are invaluable in patients with EDS. The POTS, they help with episodes of dizziness, a seizure. They can actually detect that. In pain, they protect the limb from being injured or touched. They help boost confidence in owners and makes them more independent, especially in kids. We've had a number of patients with EDS actually go through college just because they had a service dog with them. They help with balance. They can call for help, open doors, pull wheelchairs, help with anxiety. These are 3. I did a random search. I found these 3 organizations: Pause with a Cause, Needs, Freedom Service Dogs. These are voluntary organizations that can help you get a service dog. I think it's a very useful method of managing function, not used as much. Medicinal marijuana is coming up a lot. I can put this in one sentence. Medicinal marijuana works amazingly well in patients with CBD, with EDS. I don't have an explanation why, but we've had patients where you can give them any amount of narcotics. They have all sorts of reactions, doesn't work as well. Give them a tiny bit of medicinal marijuana and the results are amazing. So it's reasonable to try. Like everything else, it doesn't work for everyone, but if it does work, it's worth doing it. Again, you can vaporize it. You can take it as an edible. You can even use it as a topical over joints and muscles. The beauty of this is that it doesn't affect mast cell activation syndrome as much as NSAIDs and opioids do. So how does it work? There are 2 types of receptors in the human body called CB1 and CB2. CB1 is found in the brain. CB2 is found in the rest of the body, including the central nervous system. Chemicals that cause inflammation in the body are modulated by cannabinoids. So hence, if you apply cannabis, like if you apply topical medicinal marijuana, it might be helpful because these receptors are found in the entire body. There are 2 substances in medicinal marijuana. One is called THC, and the other one is called CBD. THC works on the CB1, so it is responsible for the cognitive effects. CB2 works for pain and also helps with autoimmune dysfunction. The problem is that for medicinal marijuana to work, you have to have both in there. It's called the entourage effect. THC and CBD have to be there and together. But you can play around with it, and daytime use, we can have a higher amount of CBD for pain and a lower amount of THC. And then you can reverse that at night, where you can have more THC and lower CBD levels. That'll help with sleep at night. So these are some of the options to try. I know it's not approved in every state, but more and more states are now coming up with it. It's really worth a try to see if it makes a difference. It does make a difference. It can help with nausea. It can help with pain. It can help with function, sleep. But the hard part is finding the right combination, the right ratio, and the right way of taking it, whether as a tincture or as a topical or as a edible. It all depends on individual people. So we've talked about all these therapies, different things that can be done, and some wonderful speakers have talked about different things that can be done. But what is our expectation from each of these therapies? Like how do we go about this? So this is what we call as the NC10 rule. The NC10 rule is very simple. You use one therapy, one treatment, and expect to get, say, 10% relief from it. You add another therapy and you get another 10% relief from it. It helps you another 10%. So now you've got 20% if you take 1 and 2. So finally, so as you go on, as you add on you add a third one, you add a fourth one, and you're now getting 40% relief. And finally, if you add 5 different things, 5 different things could be anything. Say, let's say physical therapy gives you 10% relief. Let's say the NSAID gives you 10% relief. Medical marijuana is another 10%. Compression garments is 10%. So on. A combination of 5 of these therapies or treatments, if they give you 50% relief, you're good. LDN, this is another drug. It's called naltrexone. Naltrexone is an old drug that was approved 30 years ago for the treatment of addiction. But when taken in a small amount, it has been shown to help with pain. So the dose you're looking at now over here is 1.75 to 4.5 milligrams. It's amazing in how it works. So taken in a small dose, it can help with nerve pain. It can help with muscle aches and pains. Again, like every drug, it doesn't work for everyone, but it's worth trying it. The risk-benefit ratio is clearly in favor of the benefits. Initially, it might cause some insomnia, so you can start taking it in the morning when you want to do it. It does cause mild headaches, but what patients with EDS have reported is that they have increased physical activity, their flare-ups are not as bad, and they have better tolerance to pain. The recommendation is to try it for at least 6 months. It's actually a very inexpensive drug. Any compounding pharmacy should be able to make it. There's a really good website called LDN Research Trust. LDN Research Trust, they have lots of information on this. It's best to avoid opioids when you're taking LDN because it counteracts that. One of the concepts about chronic pain is central sensitization. This basically applies to all chronic pain conditions. So what happens is when the spinal cord in the brain gets flooded with a barrage of pain signals, the nerves become sensitized. The brain and the spinal cord become hypersensitized. And so what happens is simple things like simple touch can produce abnormal responses. Sometimes loud sounds can trigger a pain in your arm. A classical example is migraines, where bright lights and loud sounds can worsen a headache. This is a quick explanation. The brain and the spinal cord are what we call as the central nervous system. Normally, when an injury happens, a signal travels up the nerve, up the spinal cord into the brain, and then the brain in turn reads that signal and sends a message down back. Once the injury heals, the signals stop and everybody goes back to their business. In chronic pain, because there's a barrage of pain signals going up and down constantly, the entire central nervous system gets sensitized. So minor touch, minor stimulation can magnify the pain a lot. So in these cases, the point I'm trying to prove here is that in patients with chronic pain, treatment of central sensitization is far more important than going and chasing the nerve over here. Because if I do something to this nerve to relieve the pain, it's not going to help because it's still there. My central nervous system is still sensitized. One of the drugs that we talked about was LDN. LDN has been shown to help with central sensitization. Graded motor imagery. This is really simple. It's a great technique. There are 3 steps to it. There are stage 1, stage 2, and stage 3. In stage 1, the best thing to do is if you go to this website called gradedmotorimagery.com, you'll see all 3 steps. In the first step, there's an app which is called Recognize, and you basically, it flips through pictures of left and right, and it helps your brain recognize it. So what happens is, the theory behind this is that in chronic pain, especially what the brain does is it sort of neglects the area this pain is coming from. So for example, if I have pain in my right knee, intense pain in my right knee, my brain tends to neglect it. And this graded motor imagery helps bring that back in place. The first stage is to do this recognizing left and right, from training the brain to recognize left and right. The second step is that what is called as explicit motor imagery. So the idea behind this is that when you start to think of a movement, so if I start to think that I'm going to lift my arm up, 25% of my brain neurons start firing. They start working even before I started moving. So looking at a picture of someone moving triggers some of these motor neurons, triggers some of these motor nerves in our brain. So that's in stage 2. And finally, stage 3 is where you can do the same, we can do the exercises hidden behind a mirror. So in this case, her problem is in the left hand. So she hides the left hand behind a mirror and looks at the mirror, looks at the right hand in the mirror, and it tricks the brain into thinking that's your left hand. And that's in stage 3. Again, gradedmotorimagery.com, they have an excellent website that explains all this, and you can do all of these exercises there. These are the 3 steps: left and right discrimination, explicit motor imagery, and then finally mirror therapy. Pain receptor behavior. This is something I want to touch about real quick. One of the things about being on pain medicine for a long time is that the receptors, that is where the receptors are the keyholes where these drugs work, they get down-regulated, which means they're not as sensitive as before. You'll always see, oh, I was taking this drug and it was helping me a lot before, but now 3 years later, it's not really helping me as much. It's because they're starting to down-regulate. One of the things to do is, if you stop the drug for some time, the receptors get upregulated again. And so restarting the drug gets a better response at a lower dose. This is what I call as a drug holiday. The other technique is to switch the drug to a different class. So you can, if you're on opioid, you can switch to something different. And then once your body starts getting used to that drug, you can switch back to the first drug again. And that's called drug rotation. So finally, I want to talk about sleep and EDS. Pain keeps them awake from sleeping. The problem is that people with dysautonomia of parts are pumping so much adrenaline during the day in order to keep their pressure up that they are now loaded with adrenaline when they go to bed. So they have an increased number of sleep arousals. They wake up, even though they've slept all night, they wake up tired. The brain is tired. They feel unrefreshed, which is what is called as non-restorative sleep. This is a concept that I learned from Dr. Alan Posinki, amazing physician on EDS and sleep issues. This is actually a slide from him. This is the brain activity. So there are 2 nervous systems in our brain, in our body. The sympathetic is the red one, and the parasympathetic is the blue one. And you can see the brain activity at sleep. The brain is firing away at night. This is after it's been treated. We can see how the signals have all subsided. A good drug to try is a beta blocker for this. Beta blockers are drugs like propranolol that dial down this increased sympathetic activity in our body. It's a drug that's recommended for the treatment of POTS. So you can see what happens in non-restorative sleep is that there's been some amount of firing of the nerves over here. Once treated, it calms down this firing. So what I'm trying to say is that just taking a sleep medicine is not going to make the difference. Just taking melatonin is not going to make the difference. What's going to make a difference is dialing down the increased sympathetic activity, dialing down the increased adrenaline that's working there, helping control POTS, controlling mast cell activation syndrome is what's going to get you this picture. Another group of drugs to try are the alpha blockers called the clonidine or guaifenesin. Technically, they do not recommend taking beta blockers and alpha blockers together at the same time. But when taken, some cardiologists have been doing that for non-restorative sleep. A small dose of beta blockers and a small dose of alpha blockers can help that. Again, good sleep hygiene, no watching television in the bedroom, comfortable mattress, dark and quiet room, no digital lights in the bedroom. So finally, I wanted to go to connecting everything that we've talked about. Fatigue can happen from EDS, POTS, mast cell activation syndrome, pain from all those three. Headaches can be all those three with tethered cord, cherry malformation. So there's a lot of these dots that we have to connect in order to be able to figure out what's going on. Once we connect, so the first thing is to figure out the dots. Which are the dots? So we have patients with EDS, POTS cell, mast cell activation syndrome, tethered cord, cherry malformation, craniocervical instability, TM joint dysfunction, all sorts of issues. So as we find these dots, then the question is, how is that influencing the rest of the body? How is that influencing function? We work on that, but it's also working on each one of these dots to help get back function again. Sense of anxiety can happen from mast cell and POTS. So with this, I wanted to thank you. I wanted to thank John and Deanna for bringing this together. Unfortunately, I had a really long day. It's going to be very hard for me to take questions, but that's my email address. I'll try my best to answer those questions, but I hope this presentation was helpful.
Thank you, Dr. Chopra. Wow, that was a lot of information, great information that you're able to go over for us and connecting all of these issues that a lot of us experience, and is very valuable. Thank you so much.
You're welcome.
And it is getting close to our end time, so as he mentioned, we're going to go ahead and close up the meeting here in a couple minutes. And wanted to remind you to go back and listen to Dr. Chopra's part 1 of the 2017 series, as well as his series that I believe appeared in 2014. There's some additional valuable information there. And I want to remind everyone that our next webinar is going to be on June 6th, and that's going to focus on gastrointestinal issues with EDS with Dr. Chilimsky. At this time, I'm going to go ahead and turn it over to John to finish up giving you a little bit more information and closing out the session for tonight.
Yeah, thank you very much, Dr. Chopra and Deanna, for your wrap-up. I wanted to remind people that this program is sponsored by Body Support Store, where you'll find about 250 products. They're selected by EDSers for EDSers, so that helps fund this program. And we are trying to do it monthly, and we've been very successful. Deanna's been very good organizing these. So look forward to having you attend a future conference. And again, thank you, Dr. Chopra. We're going to call it evening. Good night.
Thank you. Thank you.
Good night, everyone.